so much. That's, again, for this sort of conflict, that's firstly, my setup, I prefer, when it's feasible, the ipsilateral femoral punctures, or starting from the CFA or starting from the SFA for treating the popliteal and BTK arteries. Six French sheath to treat FEMPOP inflow if it's necessary, or we go directly with a full French sheath done to the popliteal artery. That's, by the way, it's very important to be very close to the lesion in order to increase the pushability and the support, and also the quality of contrast injection. And what we usually do, we select artery by artery during the control and during the recognizations. By the way, that may decrease the quantity of contrast. And we may switch for larger sheath if it's necessary for kissing balloon if it's required. What have changed since the last year? Of course, this is the guide wire to be able to cross and to access down to the artery. Thus, initially, we have used the V18, and we still use the V18 with what is very important also, this is to curve the tip of the guide wires and to use a support catheter to penetrate the proximal fibrous and calcified cap. And after, you have to navigate. But now we shift largely for the ASAI guide wires, and the first of the escalation that is sometimes required. The first of one, this is the Gladius that we use very largely in our centers. Thus, again, guide wire are dedicated to different technique. For the intraluminal approach, we use the O18 and O14, especially to navigate or to cross around or below the ankle. And once again, this is the escalation of guide wire. First, this is the Gladius, or sometimes the V18. We also use the command we use after the Albert, the Victory, and the Astato, especially if we need to perforate or to penetrate. I mean, it's very fibrotic or heavily calcified. Here is an example. This is the Albert, and you see just below the Astato that is really dedicated for, this is a perforating guide wire. We use the microchannel technique with a sliding technique or penetration technique, especially at the proximal and distal cap. And to navigate sometimes, if there is no microchannel, we may use the drilling technique. Thus, this is the concept of the microchannel. It's easily acquired skill. This is in most common lesion. What remains very skilly, this is to penetrate and to start the navigation, especially on the proximal cap, and sometimes to re-enter very properly with the distal cap also. You see one example here of navigations. Thus, this is an example of connection to the dorsal arch. We are here using the Gladius and a support catheter that is here, the Trailblazer, that is the softer of all the support catheter we may use, but there is a very tight loop to re-enter into the dorsal pedis. Yeah. Thus, you see here the ability to navigate of the Gladius that may reach the dorsal arch quite very easily in that example, and of course PTA and direct control. And you see that we inject directly with the support catheter into the artery. Thus, one more example. This is medium length peroneal artery occlusion that is re-injecting the dorsal arch via the anterior collateral arteries. Thus, here we use the Albert that give you more torqueability and penetration power that is also increased if it's necessary. This is, and no fear and no hesitation if it needed to use the lateral view of the foot and or the ankle to clearly understand where you are and moreover where you are going on. Of course, the guide wire, but what is also very, very important, this is the support catheter, and also for the subantimal approach. Also, the suboptimal approach has changed since the last year. Of course, using the O18, and sometimes, especially for the popliteal artery, we may use the O45. Thus, support catheters or over-the-wire balloon may be used that increase the pushability, that also increase the penetrations, and that may help direct the guide wires. And moreover, you may control the loop. Thus, we use as a support catheter the Trailblazers, the Navicross, the Quickcross, someone you do not have in the US, so-called the Surgeons. We also have the CXI and the Rubicon, and also the Seeker. Thus, and we may deal depending on the tortuosity and the support we need to have. One example, this is anterior tubular artery with an occlusion. Here we use a Gladius, and to use the subintimal way down to the foot. That was impossible to stay into the Schulman due to the long occlusions, but we can also loop these Asahi Gladius guide wires, and we need to maintain the loop very strongly, and also the tip of the guide wire keeps its shape after to re-enter distally into the arch. Thus, this is a pure example here. This is and you see that you are reaching, it's very easy after to unloop and to re-enter distally using the Asahi Gladius. And this is the control after the PTA. Thus, what also have changed with the subintimal way, this is we have very dedicated guide wire. Likewise, the Gladius MGPV, MG18PV, that is really dedicated for navigating into the subintimal space. Also using support catheters, and mostly we use this or the CXI or the Surgeons, depending on the pushability we need. Okay, this is into the arteries, but sometimes it's necessary to practice the retrograde approach. Thus, of course, we have the micropuncture kit that is 21 gauge needle, but my favorite punctures is made using a 16 gauge needle that give you more support, especially if we need to go very deep, especially for the peroneal artery, when we also have long 16 gauge needle if it's necessary. Of course, this is a sheathless technique. Guide wire is inserted directly. We use all the V18 or the Gladius, or sometimes the Gladius MGPV, of course, plus the support catheter to maintain the loop or to deloop if it's necessary. Thus, this is an example of the peroneal punctures. On the imaging above, you see that I'm using the micropunctures, but on the imaging below, I'm using the 16 gauge needle to go very deep into the peroneal artery. Of course, we also sometimes use the anterior tubular artery punctures, but anyway, everybody knows that. This is very helpful. That represents approximately only 5 to 8% of our procedure when it's needed to use a double way guide wire technique. Thus, what is the treatment strategy after to treat the BTK and the popliteal artery? Of course, we use POBA, depending on the diameters, the length of the wire or rapid exchange, and we may use some high-pressure balloon dedicated for the BTK arteries. For salvage, again, no hesitation. When we have the discussion this morning with the connection between anterior tubular artery and the dorsal arch, if it's necessary, also around the ankle, no hesitation to scaffold the artery. And we have very short nitinol stent, or if it's necessary, some balloon expandable stent. And we also have drug-eluting stent if it's necessary. What is the place of the long DCB? There is no answer right now. Atherectomy devices, we use the Phoenix. I think it's really worth the cost to use the atherectomy devices, but only for the proximal third of the BTK artery. Distally, we have some disasters. So in the end, what is crucial? Of course, to know all the skills, but this is to have a very large armamentarium that is always necessary and required in most of the procedures. Thank you for your attention.